Now, our final speaker of the day is Dr. Wang attending physician at the International Medical Service Center, TVGH. She will present hospice and palliative care for cancer patients, focusing on compassionate care, dignity, and end-of-life support for oncology patients. Now, please welcome Dr. Wang to the stage.
Hi, good afternoon, everyone. I'm Claire. I'm a family physician, and it's my pleasure to share with you the hospice and palliative care for cancer patients. And I will talk more about the experience and the models in Taiwan. So let's start from a real case. So this is a man. He is 65 years old, and he had hypertension, diabetes, and generally he's generally well and living with his family. However, 2 weeks ago, he started to have abdominal fullness and constipation, and after that, he started to vomit and have poor appetite. And he visited our ER, and terminal stage of colon cancer was diagnosed. And there are lymph node metastasis, and he received emergent colostomy followed by a laparoscopic surgery. And he received chemotherapy for 1 more month. But soon the cancer progressed and with multiple metastases to liver, to lung, and soon he had a sepsis, and he admitted to the hospital again. And also, he also had poor appetite and electrolyte imbalance. So the medical team suggests him to insert a nasal gastric tube, which is very common in Taiwan, but the patient, he refused it. And soon he had a septic shock. And what's the next step for the patient? Should we do the intubation or do the CPR? Okay, it's time to talk about hospice and palliative care. So hospice and palliative care, they are quite similar, but palliative care is of a broader spectrum, while hospice care is focused on the end-of-life care. And according to WHO, the goal of palliative care is to improve the quality of life of patients, but not only the patients, but also their families. And we have to treat the pain, but also other physical, psychosocial, and spiritual conditions. So when should palliative care started? It can be started as early as the diagnosis of the disease. And as the disease progresses, the need for invasive treatment is decreased, and the need for palliative care is increased until the end of life. And recently in Taiwan, we started to introduce advanced decision, which also named living will. And this can be started even earlier, even when the patient is generally healthy. And according to the most recent review, Taiwan ranked number 3 in the world for the quality of days and dying. And number 1 is UK, United Kingdom, the mother of the hospice and palliative care. So Taiwan is number 3. How can we achieve this? There are many key reasons. So Taiwan, 1, because we are of a rapidly aging population. And as more people are growing older, the more people will have chronic disease like cancer or dementia. So the need for end-of-life care is increased. But however, there are too much medical spendings on taking care of them during this stage of life, and the spending is increased hugely. So we want to reduce these medical costs, but also to improve their quality of life. Because during this stage, many of the treatment is useless, and even the patient will suffer from it. And the other major reason is that cancer has been the number 1 leading cause of death in Taiwan for already 40 more years. I believe it's the same in Vietnam. And so the cancer in Taiwan, the majority, the patient will die of lung cancer, followed by liver cancer and colorectal cancer. So about 35 years ago, in 1990, Taiwan started our first medical practice in hospice and palliative care. A Christian-based hospital established a hospice ward. And after 9 years, in 1999, we have established an academy to provide the training and certification for the specialties across Taiwan. And later on, there are two important laws passed in Taiwan. And these two laws are the first of its kind in Asia. So these two laws are very important. We call it the two pillars of hospice palliative care. One is Hospice Palliative Care Act, which started from 2000s, and it covered the patients with terminally ill conditions. And two, it's the Patient Autonomy Act. It started from 2019, and it covered more conditions, including irreversible coma, persistent vegetative state, severe dementia, and other unbearable or incurable conditions. This is the letter of intent for the patients, if the patient is clear and he can sign it. But for the patients, if they lose conscious, the family or their healthcare agent can help them to sign this. So in this letter, they can refuse or to withdraw some life-sustaining treatment, such as intubation and CPR. And their decision can be registered in the IC card. Every Taiwanese people have this National Health Insurance IC card, and we carry it with us to all the healthcare facilities. And this is the living will, advanced decisions. So people can write down their decision by themselves when they are clear. And they can make decisions to refuse life-sustaining treatment. And more, they can refuse artificial nutrition and hydration when they meet some special conditions during their life. And the hospice palliative care can be provided across different settings. So we provide it in outpatient, not only face-to-face consultation, but also online. And inpatient, we do have hospice ward, but hospice ward is not enough, so we started shared care, which means the hospice palliative team, they coordinate the care with the original department, for example, the oncology department, and we provide the shared care. And we also provide it at home, but also some long-term care facilities, and also provided in the outpatients. And we work as a team, and we integrate multidisciplinary professionals to provide care for the patients, but also to the family across the whole journey. So far, across Taiwan, there are more than 80 wards, hospice wards, and more than 800 hospice beds. And there are more facilities to provide community care. But still, the need is increasing and the demand is high because in Taiwan, there are a growing public awareness to accept a good death. However, there are still room for improvement because, as you can see, the advanced decision coverage rate is still not high. But fortunately, all of this care is covered by our national health insurance. And for patients who meet these 5 categories, they are fully supported. for terminal cancer, for terminal motor neuron disease. For other terminal non-cancer patients, such as dementia, Parkinson's disease, terminal heart failure, lung disease like COPD or lung fibrosis, and other kidney, renal failure, and liver cirrhosis, MDS, and even the elderly people with frailty. And we also cover the rare diseases and conditions, some conditions, and the people who meet the criteria according to the Patient Right to Autonomy Act, including some advanced disease like ALS or Huntington's disease. So this is the care models we provided across Taiwan. I would like to share our team as an example. In our hospital, we incorporate several team members from physicians, nurses, spiritual carers, volunteers, music and art therapists, psychologists, social workers, and also we have a therapeutic dog. His name is Opa. It's very cute and it's also one of our favorites in our team. And our team is the education and training and also the research hub, not only in Taiwan, but also across Asia. Every year, we have received many health providers to receive training. And the team is very busy. They have a busy schedule. And most of the schedule are multidisciplinary meetings to discuss what's the best care for the patients. So for the statistics in patients, this is the facilities we provided in the hospice ward. We have a total of 16 beds, and we have a garden, we have a bathtub, a multifunctional recreation room, and 60% of them are cancer patients. And most of them are of colorectal cancer, followed by lung cancer, pancreatic cancer, liver cancer. And for the non-cancer patients, most of them are of pulmonary disease, followed by chronic renal failure and dementia. And many of them, they stopped hemodialysis during this stage. And for the source, most of them are referred from other wards. And some of them are referred from the emergency room or outpatient clinics. And after admitted to hospice ward, most of them died in the hospital. And some of them, they discharged back to home to receive home care or to transfer to other facilities. So for the shared care inpatient services, most of them are referred from the oncology ward, followed by the ER, the chest medicine, the GI department, and ICU as well. For the outpatients, so most common symptoms for them is general malaise, pain, poor appetite, and constipation. So for the home care, 60% of home care are for non-cancer patients. And we have nurse visit, maybe most of them visit twice every week. And the doctor visit once every week or every 2 weeks. And also other team members will visit. They will visit at the patient's home or other long-term care facilities too. And in average, the home care is around 3 months. So back to these patients. So when this patient is diagnosed of cancer, our hospital has a cancer registry system, and the patient will log into our system. And usually, we will have a multidisciplinary conference between different specialties to discuss the treatment plan. And the record of the meeting and the treatment plan is logged into the system too. And if the patient change the protocols of the treatment, they will update the treatment plan. So all the team in our hospital can review this in the system. Beside the cancer register system, which is incorporated into our EMR, we also incorporate their medical records, their medication, their nursing records, and their consultation records from all kinds of disciplines. And also the shared care notes will also can be reviewed in the system. And from the nursing records, we can see important message, including the patient's vital signs, but also the pain score. Pain score is very important because for many cancer patients, pain is a common symptom. So we have to assess the pain and to see how severe it is. And we have to see what type of the pain it is, whether it's physical pain, social, emotional, or spiritual. And we have to help them to deal with it. And for each type of pain, we provide appropriate painkillers according to their mechanism. So our team will provide the painkillers according to their needs. And we follow the 4 steps of the ladders. And our hospital, we do have all kinds of painkillers. And in some terminal conditions, we even provide a terminal sedation for some very severe cancers. But besides painkillers, the adjuvant therapy is also an important part. In our hospital, we provide the art therapy, music therapy, the animal therapy, and we have spiritual psychologist support. We do the massage, we do the kinesiology tap, animal therapy, comfort oral care, and also acupuncture too, and other herbal medicine too. And in this, I would like to also share another important part in Taiwan is about the management of these painkillers. For painkillers like opioids, it's very easy to get addiction. So in the United States, it's a problem. But in Taiwan, the FDA has a regulation on it. Each prescription, there's upper limit from 1 week to 2 weeks, according to different kind of formulations. And every patient or their family have to write down the note of the what time and when and how much dosage the patient using on the note. And the medical team have to review it during every visit. And every empty bag or empty ampoules should be returned to the hospital. And then they can get another new prescription. So once this patient, he or she decided to not to receive further invasive care and to stop or withdraw life-sustaining treatment, we will invite 2 physicians from relevant specialties to confirm that the patient is in the terminal stage. And once it's confirmed, and then the patient is referred to the Hospice Palliative Care team. And the team will have a shared decision-making and the family meeting with the family and the patients. And then the patients will introduce to different models of care. And finally, we help the patients to have a good days. And after the days of the patients, the team provide support, grief support for the family. These are the activities we have in our hospital, like a wedding ceremony, birthday celebration, mahjong, to engage the patients more. So what's unique in Taiwan is that we integrate most of the medical records in the EMR system and also integrate it into everyone's NHI IC card. And when we carry it, and every hospital can review this information across Taiwan. And also their DNR order or their advanced decision will upload to the nationwide online system. So also every health providers can review it online. So the patients don't need to sign the documents from A to B hospitals. So we integrate this into different settings, and we provide multidisciplinary care to improve the quality of life and to reduce the medical cost. And over the past years, we also established systemic training programs, not only for the health providers, but also for the family, the volunteers, and the general public too. And we do have many non-government support from all kinds of foundations or academy. But we do have some challenges. So most of it is about the cultural issues, because in Chinese, many of people still have a taboo to talk about death. So many of the patients, especially non-cancer patients, they are referred to the hospice palliative care later during in a later stage. So these are the rules for our future improvement. So in conclusion, Taiwan has more than 35 years of experience in providing hospice palliative care. And we are very happy to share this experience to our friends. But we cannot do it alone. We need teamwork, and we hope we can team with Vietnam to help our patients all together, to help them to cure, to relieve, and to comfort. Thank you.